Now let's move on to the last presentation from the field. It's from Nigeria, Maiduguri. It's on integrating TB and nutrition, which we haven't talked much about until now, and then how to address stigma. It's presented by medical doctor Abdullahi Chara from the project. Please go on.
Hello,
Dr. Chara.
I am Dr. Chara, one of the doctors working in the MSF 40 project in Maiduguri, Borno State in northeastern Nigeria. In early 2017, in response to the high levels of malnutrition seen among children displaced into Maiduguri city due to armed conflicts, the MSF opened a nutritional project. The program consists of both inpatient and outpatient therapeutic feeding centers called ITFC and ATFC respectively. Tuberculosis is an important morbidity among malnourished children, as weight loss is one of the primary features of the disease and can be a cause of severe acute malnutrition. Since the start of the nutrition activities in Fori, children have been screened and diagnosed with TB according to MSF algorithm. The need for appropriate TB care along with nutritional support for malnourished patients with TB led to the integration of the TB programming into the project activities shortly after its opening. Now, here is the story of our project's TB integration. We admit children aged 1 month to 10 years with SAM or MAM into the program, and they are either stabilized first in the ITFC or cared for in the ATFC. We are currently the largest inpatient nutrition facility in Maiduguri, receiving patients all over spontaneously or through referrals from other facilities. TB screening is done using the standard questions about symptoms as well as history of contact. A chest X-ray is done for patients with suspected pulmonary tuberculosis. Once a diagnosis of TB is made, the MOH is then informed and the patient is enrolled in the national TB program, and drugs for the patient are sent to the project. The majority are diagnosed in the ATFC, but a few have been diagnosed via contact tracing of siblings or relatives enrolled in our nutrition program. All patients with TB are discharged to the ATFC where care is continued. However, children over 10 years and caregivers suspected of TB are sent to the MOH for further assessment. As more malnourished patients were admitted with tuberculosis, we collaborate with the Ministry of Health Borno State to enroll these children in the national TB program and initiate treatment for them as soon as possible after diagnosis. The Ministry of Health was extremely cooperative and agreed to not only supply drugs on demand, but also to provide drugs to the project in priority and safeguard a stock to the project against rupture. These allowed us to organize activities without concern about drug supply. They also allowed patients diagnosed at our facilities to continue treatment in the facility after discharge. With this foundation, the project began to organize care for TB patients. And by the end of 2017, we had assigned a day in the ATFC to follow up patients, made dedicated boxes for each patient containing their supply of drugs, and set up TB treatment cards modeled after the National TB Program treatment cards. Here is a summary of for these TB activities from 2018, our first full year of reporting, to 2020. From 2018 onwards, 100% of children with TB were tested for HIV. From 2019, 100% of the children with tuberculosis have been enrolled in the National TB Program. We had a loss to follow-up rate as high as 49% in 2018 and a low of 5% in 2020. The HIV-TB co-infection rate ranged from 3 to 11%. Now, taking a closer look at 2020, despite the challenges of the COVID-19 pandemic, we enrolled 77 patients into the TB program, the majority of which were cases of pulmonary tuberculosis. We had a mortality rate of 16%, a loss to follow-up rate of 2%, and covered 7 of the patients with pyridoxine during treatment. In the first month of the project, TB cases were often lost to follow-up or left untreated because of the cumbersome diagnostic process used by the MOH and the then unestablished collaboration for TB drug supply. Once the collaboration for drug provision began and the MOH accepted the diagnosis of TB based on MSF algorithm, with supporting evidence of sputum and chest X-ray, this barrier was removed. These, along with the system of individualized drug packaging, improved the enrollment and successful treatment of TB patients in the project. On our end also, our data collection and monitoring systems were poor, leading to unreliable follow-up for patients. We improved our data systems in 2018 and 2019 with dedicated monitoring for TB ATFC patients and reduce the follow-up problems due to this. One barrier we removed by the end of 2017 was limiting transfer of care and risks of being lost to follow-up that way. Specifically, patients started on TB treatment in Fori continue their treatment until completion of their therapy in the ATFC despite being discharged from the nutritional programs. Now also, post-ATFC discharge, patients were maintained on non-therapeutic supply of BP100 throughout their TB program treatment. In 2018 and 2019, specific focus was placed on improving the quality of care for TB patients with a dedicated doctor assigned to the ATFC, paying special attention to the TB patients. And more work was done to improve care for patients with HIV and TB co-infection. Thanks to these modifications, the defaulter rates dropped but remained higher than desired in 2018 and 2019. Our greatest success in overcoming this challenge of defaulting came with improved health promotion activities supporting TB patients despite COVID-19 in 2020.
Since the program started in Fori, stigma has been an issue for many patients, leading to them avoiding care or being lost to follow-up. Thanks to effort by the team and events around World TB Day in 2018, stigma in the community has been greatly reduced. In 2020, the health promotion team was invited to be involved in the care of TB patients from diagnosis onwards. We took the opportunity to try a few things to improve the follow-up of patients. The TB patients were made a priority for community health visit by the HP team, so families were called on and visited at home. Transportation was noted to be a barrier to attending regular visits, so the HP budgeted money and provided transportation for families of TB patients. This was phased out in 2021 and replaced by food rations, rice, beans, cooking oil, and seasoning. For patients who are in areas that are hard to reach due to conflict, we worked with their local communities and other NGOs to facilitate their visits and follow-ups. Families were also supported to find and bring other members who were potentially TB positive for screening and testing. We facilitated their visit to Fori Health Center and followed up the results with them. This was how we improved the care of our TB patients and greatly reduced their loss to follow-up rates and kept it down even throughout the COVID-19 pandemic.
Looking forward, our work is not done. We still struggle with higher than desired mortality in our project. So in 2020, we will target quality of TB care by allocating more staff to review the program and standardize TB management procedures and protocols for new doctors, nurses, and health promoters. We hope to continue to put more resources into data collection and analysis. We will aim for 100% Paediatric supplementation this year, and we hope to start to support TB prophylaxis treatment for relatives of TB patients under our care. We are also exploring the option of on-site TB testing with GIN experts. Thank you.